Venice traditionally has been a place where people meet from different parts of Europe to discuss new ideas, to develop new things.
We come here every year with a policy-relevant topic, and then we leave with a much more nuanced understanding of the differences from different settings.
Most useful is that we have people from different countries, from different positions.
We learned that this formula works.
It's a very special audience.
Venezia non ha bisogno di pubblicità.
I think the Observatory Venice Summer School has become somewhat of an institution, and no summer school is the same.
Buongiorno, benvenuti a tutti.
Good afternoon, ladies and gentlemen. I welcome you on behalf of Minister Lanzarin and Mr. Anni Chiarico, who is the Director General of Healthcare and Social Services. Welcome to the meeting of the Observatory, to the summer school, which has been organized for many years together with the Veneto Region. This is the 17th edition, marking an increasingly stronger collaboration over the years with all the partners of the Observatory. Today, it is our tradition to have this international meeting, which has become indeed very important. After the COVID years, we have become hybrid. We meet in presence and online so that we have a very wide participation. We are here to talk about a topical subject, and that shows that the committee of the Observatory always organizes a very well-chosen meeting. We are here to speak about security. Over the years, we have talked about aging, primary health care, centeredness of patients, skill mix. These are all topics which have accompanied us all over the years. After the COVID pandemic, we spoke about COVID hospital, digital health, and innovation. We do believe that this meeting will be extremely interesting for the participants to the summer school and those people who are connected online and who will have the possibility to get very high quality presentations. So enjoy the meeting. I'd like to thank the Observatory, the director, Mr. Figueres, and the co-directors of the summer school, which has started on Sunday and is going on very well. Thank you very much for coming, and welcome to those who are listening online.
Yes, thank you, Antonio, for these words of welcome here in this beautiful Palazzo Franchetti. And we always like to come back to this place. It really symbolizes what Venice stands for. Also, Venice has strong relationships to many health topics, including health security. My name is Reinhard Busse. I'm a professor of healthcare management at the Berlin University of Technology and the standing director of the European Observatory Venice Summer School since the beginning, and I'm one of the co-directors of the observatory. I have the pleasure to chair this summer school on global health security, which I will introduce to you in a minute, together with my colleagues Isabel de la Mata from the European Commission and Martin McKee from the London School of Hygiene and Tropical Medicine, and also one of the co-directors of the European Observatory. You will meet them in the second part of today. Can I have the slides, please? Big on presentation mode. Yeah. Yes. What I thought I'd do, especially for those people who join us online, but also as a recap for those people who sit here who have been taking part in the summer school for the last 2 days. I'm trying to give both an introduction into the summer school and try to recap where we are, what we have heard so far, and where we pick up this afternoon and what is still to come over the next days. So we have chosen this year, after all the other topics which Antonio has mentioned, we have chosen health security, from public health to strengthening health systems. Those of you who have signed up for the summer school have hopefully read this text and not only signed up. For those now joining for the first time, we said in the invitation to register for the summer school that health security and the concern how to increase it is an increasingly important concern, both at the European but also at the global level. We are in Europe, so we have a focus on Europe, but we take it as a challenge, and it is a challenge as we have seen in the pandemic on the global level. The course will address what health security is and how it affects the different parts of health systems and health infrastructures. The implications for national health systems that stem from new European and forthcoming international legislation will be explored, and participants will discuss the themes of preparedness, response, and resilience to cross-border health threats in more depth. There will be also the opportunity to work on how to strengthen health systems in their public health and also healthcare capacities and face threats beyond pandemics. So clearly it's a topic, and you will see over the next few minutes when I introduce to you what we have done so far, that it is shaped by the experience of the pandemics. We had the issue of global security before the pandemic, but we were not as aware as we should have been. And now the pandemic has taught us to rethink this issue and be better prepared, look at our health systems, whether they are prepared, and this is the topic of the summer school. So inevitably, we are looking back to the experience of the pandemic, but this is not primarily a school of how we have dealt in the pandemic, but what this taught us how to be prepared for the future, how to shape our health systems. The next slide, please. So what we have done, and it is always the challenge of the team preparing such a summer school, how do you cut the cake? Because clearly there are many different interrelated aspects when you tackle an issue like this. And we have cut the cake into 5 pieces. And these 5 pieces are the building blocks which we are addressing. And I have marked the first 2 in bold, because these are the 2 which we have already looked upon, while the other 3 are still to come. So what have we done in Module A? It was called Setting the Scene, Health Threats and the Challenge of Health Security Across Europe, so that we get a picture where we are, how far the experience has brought us, what we have learned, how to better prepare for the future. Then Module B, and we are in the middle of it, it's called A Resilient Health System, the backbone to health security, but realizing that the health sector is no longer alone, but that it is really interrelated with other sectors. And I think the pandemic was a very visible experience of that health suddenly not only became to the forefront, but it was also discussed how the interrelationships between health and social affairs, health and economic affairs are, and I will say a few words. Then we have Module C, and clearly we are the Observatory on Health Systems and Policies, so the health system is a focus of our attention. So the Module C, coming back to the topic with public health and healthcare health systems, will be called From Health System to One Health, picking up of this interrelationship, not only with other sectors, but with other parts of the global world, so from health systems to One Health. Then important, coming more into details, because we have already seen that communication is a very, very important an aspect of being prepared for health security issues. We will have one module which is dealing with health crisis communication, both to the general public, but also coordination and communication between decision-making bodies. And we mean all the, not only the ministries, the arm's length bodies, other agencies, public health agencies, up to the army, of how they should come together, what we have learned, how to be better prepared next time. And last but not least, and we are starting with that in a sense today by looking at international organizations. Module E is looking at the global health security architecture, because clearly global health are those issues which no country can deal with by itself. And so once we have realized that we have global health challenges or challenges to global health, then the question is what have countries do together? How can international organizations support this, and what is their role? We come back to that in the second part of this session today. Next, please. After designing this into the 5 modules, we have a packed program. And I think participants, they realize that maybe those of you who have thought they come to Venice and have a nice week of holidays, it's really a full program. But it's a program which stresses, first of all, maybe we should say that to the non-participants out there in front of your computers, it really has attracted a good list of participants. We are not a typical summer school for PhD students from universities. We are along the lines of what the European Observatory stands for. We are a summer school for decision makers, both established decision makers, but also upcoming decision makers and those who support decision makers. And the program encompasses both what we call lectures. Clearly, we always try to hope time to have for discussion. So we address the various issues I just mentioned in these modules. We also have a group work designed around an exercise, and this exercise has been used by actual decision makers, those people who should be prepared. They use the same exercise which we use here in the summer course. And we have events like this today where we move out from the island. We should say we are on San Servolo Island. So today we came to this beautiful palazzo here, and we have some social events so that people come together and have enough time, not only to see Venice, but especially to develop cross-participant links. And we know from previous summer schools that many of these relationships which are founded here, that people realize, oh, I'm working in the National Public Health Institute of country X, you work in the National Public Health Institute of country Y, that people come together and really form a network. Next slide, please. So then when we came together, and I can only recapture where we are. And clearly when we talk about health security, then we are talking not about catastrophes hitting one country, for which countries typically were better prepared, but we are talking about health security issues to global health. And so Martin McKee, my co-director here, started the summer school off yesterday. It already sounds so long ago, but it was only yesterday. And when we say, okay, we have challenges to global health, then we need to ask ourselves, what is global health? And global health has different meaning as we were told. When we hear global health, it can be global health as an instrument of foreign policy, global health as a security issue for countries, global health as charity, global health as an investment, and global health as public health. and probably the last one, but with mixtures of all the other ones. So we cannot say, even as a health community, that global health is only public health. Global health is probably all of the above, and if there is a global health challenge, we need to find a solution. We should be prepared to address it from different points. Next slide, please. Then the global health is fine. If the world would be a good place, we could relax and say, okay, yes, there are global issues, but we don't have to be prepared for a disaster, for a health security issue. But we need to understand, and I think over the last years, we need to understand what threatens global health. And the threat comes both from typically unforeseen events, and the pandemic was such thing, even though we could have known that things like a pandemic could happen and we could have been prepared. But we have seen since then the war. We thought, at least us in Europe here, we thought that we were over a war as a threat, not only to a country not to countries as such, but also to the health of the inhabitants of that country and of neighboring countries. We see new weather, climate, heat records every day. We see many forests around the Mediterranean burning. We see that climate change is a different kind of threat because it's not coming all of a sudden, but it's going slowly, and a bit like the incidence rates during the pandemic. We now feel it might also be an exponential thing happening, and so we underestimated the impact. So if we hear global security, we should be aware this is not only about pandemics from viral and bacterial diseases. We need to think of a broad spectrum of possible things threatening global health. Next, please. And then clearly, before we then started, we say, okay, we are not the first ones here in the summer school to think of what does this mean. I mean, it's a summer school. We are not here the think tank to, even though we have bright people here and we come up with good ideas in the group work, there have been people before us who have thought about these issues, and we are here to recapture. So clearly an important answer is, and question is to the answer, what can we do? What have other people over the last years under the experience of the pandemic, what have they developed? And one important document is a report from the Monti Commission. So this is Mario Monti here, and I put this here because it has a good title, A Call to Action. We can no longer afford to sit idle. We need to rethink policy priorities. It says here in the light of pandemics, but I would enlarge it in the light of global health security issues. Next slide, please. And part of the answer, and this is the European bit of the global health answer, and we have looked upon this in more detail, and you saw that already in the advertisement, that we say that the European health legislation is changing, and the global health security architecture. And we looked in detail, and still do this as part also of today's program, in the European Union Health Security Framework. And this has been established, and I guess this was new also for many of the participants, what has really been done on this level, and also for European Union perspective, how quickly this also did. When we remember some other European legislation, it takes long. The pandemic has not only shown us in our national countries how quickly politics can respond, but also on the international level. So the European Union Health Security Framework was established as a response to the COVID-19 crisis, starting in 2020. And the main aim is to protect the health of Europeans and collectively responding to cross-border health crises. And there were several pieces of legislation passed, went into effect in 2022. Next slide, please. And it has really changed the landscape. I mean, people, I think, haven't realized it because it's still new regulation to which countries, mainly countries and those in charge of being prepared at the national level have to be have to get used to. So the new elements really through this variety of regulations, and the main one is dealing with issues of cross-border health security issues, that this One Health approach, which will be looking closer, and also the health in all policies, that prevention, that this should come to the forefront, and especially the relationship between the health sector and other sectors of society is crucial. There will be a health security committee where opinions, guidance, and recommendations will be adopted. And there will be, and I come to that on the next slide, we should have national plans for health security. This will be now complemented by a European Union prevention, preparedness, and response plan, which also includes stress tests, simulation exercises, etc., where national plans will see coherence with the union plans. And the national preparedness, prevention, preparedness, and response plans will be assessed by ECDC, so the European Center for Disease Control. There will be training of healthcare staff and public health staff. There will be a network of EU reference laboratories. There will be a network of substances of human origin. And last but not least, there's an advisory committee for the recognition of public health emergency at the union level, so that we all have a clear pathway to say, okay, this is now a case of a global health threat or global health disaster which affects us across borders. Next, please. And I said we knew this, and there are international regulations which will be looking at pre-existing the European Union legislation. There are the international health regulations, a bit slow in being adapted to new challenges. We will be still discussing that. And clearly there was always the question, how well are countries prepared? And there were exercises both initiated from the World Health Organization, but also from private initiatives to assess how well countries are prepared for health security issues. And clearly this is a challenge to measure how well countries are prepared before something happens, and we don't really know exactly what will happen. And so can we measure how well countries are prepared? The next, please. And also those institutions which develop such exercises to measure their preparedness, also they are faced with the question, how should we measure health system preparedness, global health security preparedness? And we have looked upon this and seen that the traditional ones are prevention, detection, and response and mitigation. But over recent years, we have seen that the health system, and many of you will still remember that in the pandemic, everybody was suddenly excited. Do we have enough intensive care capacities? Do we have enough nurses? Do we have enough doctors? Which was not before really in many assessments of the preparedness. So the health system came to the forefront, but also, and we have seen that, and I come to that in a second. We have seen that there might be international law, but countries might not adhere to it, or might disobey it. And last but not least, the overall risk environment and country vulnerability to biological threats. Next, please. And we have seen, and this is a complicated graph here, let's focus on the left-hand side. You see on the bottom there, the scoring which countries received before the pandemic. And the countries on the right-hand side, on the right side, I marked with the green and the red circle there, are those countries which scored well. And in the pandemic, first we read these reports, US and UK most prepared for a global health security issue. But then when the problem was there, the pandemic came, we saw that they, in spite of being ranked as being prepared, that they had very high death rates. And then the debate came, why did they do so badly? And with this, we address not that you have a good plan, but you need good politicians who really take this seriously and who don't disbelieve the plans which exist in their country and communication. So the tools, not only the preparedness needs to be revisited, but also the way how we can assess how well countries will be doing. Next slide, please. And with that, and this is where we are, we came to the health systems properly. And I already said during the crisis, maybe too much from a quantitative standpoint that basically every additional ventilator is good. We realize that this is not so easy to measure preparedness, but that rather the issue of resilience of health systems is very important. So the ability to be prepared and manage, absorb, adopt, and transform to learn from shocks. So it's already a difficult thing for many policymakers to have a high-performing system in times when there are no security issues and you can plan well ahead. Then you have a sudden, but then you should be, and this is the second issue, you should be prepared for a sudden shock. When the shock comes, you need to absorb the shock impact. You should be able to still run your health system at least as much as necessary for the normal conditions and deal with the health security crisis. And then very importantly, and we are in this phase now, and resilience means that you are not going back to normal, back to where you were before, but that you learn from this experience so that you come with an even stronger health system to be better prepared for the next time. Next, please. We learned, and there are different components of health systems, and I don't want to focus on all of them. Clearly, healthcare delivery is important. Healthcare financing is important, but governance, good governance is crucial. And part of this good governance is political leadership, to have politicians who really are committed to these issues and who understand, who base their decision on available evidence and not only on ideology. Politicians who understand to coordinate the health sector issues across sectors in their countries, and last but not least, who can communicate clearly and transparently. So these are more, one could say, soft powers. It's difficult to measure when you rank countries, how will their politicians behave when it's really in a times of crisis. Next, please. This is the last one where we are and where we will be picking up tomorrow. The relationship between health and the development goal, the sustainable development goal for good health and well-being, and recognize how closely linked it is to other societal sectors, to other sustainable developments. What we now say the co-benefits. So if we deal and if we help our countries to deal with health issues, the better they are able to deal with health issues,
the more co-benefits on our sectors. A healthier population will experience less poverty, will be better educated. A better educated population will again contribute to economic growth. The health sector can make a big impact on climate change and so on. So this interrelationship is very important, and we have to also, as health people, step out of our box and say, okay, we need to talk to other people need to talk to us. Next and last slide, please. So today, this is what we have seen so far. What is global health security? What threatens it? What are we doing at the European level? What we are doing at the international level? We will now debate and come back to on Thursday. But before we come to these international issues, we have two presentations from our hosts here, from the Veneto region, and they will tell us what they have been doing with two examples on influenza and AMR, and how they deal with their health security preparedness in the Veneto region. And with that, I hope I could give you a little flavor of what we are doing in the summer school, and I invite my Veneto colleagues, Andrea Basso, Michel Donon, and Marco Milani, to join me here for the first of the two presentations. And the first one is on the it's called the PanFlu, the Strategic National and Regional Plan to Address a Flu Pandemic. You have the floor, please.
Thank you, Professor Busse. I'm here on behalf of Francesca Russo, Chief of Directorate of Prevention here in Veneto Region Administration. I'm Andrea Basso, resident in Hygiene and Preventive Medicine in Padova School of Hygiene, currently practicing at the Veneto Region Directorate of Prevention. I'd like to tell you something about how this corner of Italy, Veneto Region, is getting ready for the next pandemic. Next. COVID-19 pandemic wasn't yet over when every country, every health system started to think how to be prepared for the next one. In fact, a CDC gathered a few recommendations on how good a pandemic preparedness and response plan should be. Updated, of course. Non-specific for a single pathogen, flexible enough, and scalable. Next. In 2021, Italian Ministry of Health wrote a new updated national pandemic plan, and Veneto Region, compliantly, wrote its own version along the same line of the national one. Here, every region, has a certain degree of autonomy in writing its own social and sanitary policies. Next. I don't know how it works in Berlin or Lisbon or Brussels, but when Rome decides to take a few notes and plan what to do next, it usually ends up with one or more volume of hundreds of pages each, which may be good and exhaustive as well, but will it be good enough? Well, if we take into account what has been said by the ECDC, the Venetian Directorate of Prevention decided to scale things down a bit, next, and to do so through simulation exercise, next. Next. Well, next, please. Here you can see the participant of the simulation we built. You can see Veneto Region is divided in 9 local sanitary units. Each one within itself has the main 3 pillars of our national healthcare system: hospital, of course, the primary care and social services, and the prevention service. Each and every local sanitary unit send their representatives, as well as their health management office, to meet the regional directorate for prevention and other regional offices involved in the healthcare system planning. See, the call for a regional simulation was not only for those who work in the field, but also for the regional administration itself to work together on this topic. Next. And the answer, happily. Next. So the Hercule program started. It began last February with a series of simulations. It continued through March, May, and June. Hopefully, there are another set of the simulation on this fall, later on. And with frontline healthcare workers and management officers busy with their current routine, and we know how much they are understaffed, it has been a really Herculean effort to gather them together under the same roof, but eventually we did it. Next. All these exercises came in the form of a tabletop simulation with different work groups. You don't want to test a brand new plan on a real situation. You want to test it on a safe place, hopefully, safe enough. Next. These are the main work groups that work on different simulation. You can recognize the main three pillars: the hospital management, the primary care services, the prevention services, along with the epidemiological surveillance, governance and communication, infection control, and last but not least, procurement. The Directorate of Prevention here in Veneto produced different scenarios with facsimile of WHO and regional reports and documents describing the details of every setting. Maybe mainly we are talking about influenza outbreak all around the world in different phases, preparedness phase, alert phase, and real pandemic phase. Next. At the end of every simulation, each work group resumed what they have learned into two checklists, one with a series of action with the regional administration as main actor, and the other with action to be taken by the local sanitary unit, coherently with the main plan and the mandate of each work group. Next. In conclusion, next one. Veneto Region has been the first region in Italy to use these tools, the simulation, in order to scale down the national plan to this day. The two levels, regional and local, left the work groups enriched by an important insight in each other's roles. Moreover, they felt a feeling of empowerment, of course. It was one of the first time that the workforce on the field was involved in decision-making. Next. Every local sanitary unit experimented an instrument to test its own preparedness, and local tests will start this fall in every unit of Veneto Region. Next. Now, finally, we have an operational tool, the checklists, easily manageable. Next. Until the preparedness culture and a practice-oriented approach has reached the very last mile of our national healthcare system, we cannot say to be fully ready. Next. Hopefully, we catch up fast. Thank you.
Yes, thank you for telling us what is going on here, or has been going on, is still going on in the Veneto region. Because the two presentations touch upon different issues, there's now the opportunity to have specific questions to this first presentation, both here in the room, but also on your computers out there. I see that there are 150 people joining us online. Anybody? We have a microphone. Maybe you can tell us, how did people in the local units react to this? Were they eager to participate, or did they participate a bit lukewarmly, or how was it, the sentiment?
Well, the background of everyone was a bit different, of course, and as well as the sentiment, the feelings. But I don't know if it was the post-pandemic period in which everyone is happy again to gather together. So I don't know if it's they were just enthusiastic about their job or PTSD, actually, but they were enthusiastic.
Yes, please. Yes, first there. Yes.
Thank you. Dr. Eamon O'Moore, I'm Director of National Health Protection in Ireland. Thank you for sharing your presentation. It's always nice to see Wile E. Coyote getting some airtime, so thank you for that. I'm interested, though, in the experience of running exercises that take appropriate account of the duration of the event. We've all learned from the current COVID pandemic that the duration of the event has been extensive. I spent most of the first part of this century doing exercises on pandemic flu, which perhaps saw scenarios that were much more short-lived and perhaps didn't take account of the huge impact that a sustained event has. And we're struggling with this in Ireland as well. How do we prepare effectively for an event which will perhaps run over a course of several years and have wave impacts? So how do you get to a point of preparing with such an event? We've got a model around having an approach that is about a baseline response, a defend response when you got the alert that something's happening and you're starting to take preemptory action, an enhanced response phase, which is when you're doing everything you have to do, and then importantly, a de-escalation phase. And the principle undermining our approach as well is to apply to the most defined population, the most effective restrictions that are evidence-based for the least amount of time and have a review period built in so that you can review the impact of that. And I'm wondering if that's part of your considerations in Italy generally or the Veneto region specifically, or is that something that you're having conversations about? It would be really interesting to hear. Thank you.
Well, we started from our own experience of the pandemic, of course, like any other countries. And here in Italy, the way it struck, we realized that what we lacked most was preparedness. So it wasn't the main effort during the real period of pandemic. It wasn't not also that, but mainly the preparedness. The culture of preparedness is not to be taken for granted here in Italy. So mainly that.
Before we come to further questions, I need to ask you to stand up for the cameraman, otherwise the people online will not see who is speaking. Otto.
Right, Otto Helve from Finland, Finnish Institute for Health and Welfare. I think my question was partly asked and answered, but I would like to comment nevertheless. I think simulation exercises are such that were done, at least within my country, prior to the pandemic, and I think most of us have considered it to be impossible during the pandemic and even immediately after. So I would like to thank you for doing that and showing the way to starting these protocols again. Thank you.
Thank you to you.
All there. And please stand up.
Thank you. Hi, my name is Rachna Chawla from King's Health Partners. Just a question trying to link the simulation exercises with the importance of building trust and communicating with the public. And I'm just wondering, is there a role of communicating with the public around the fact that you are doing simulation exercises in order to prepare? Because it certainly gives me reassurance when I know that these things are happening within our system. But I wonder whether the role of building trust around pandemics starts not during a pandemic, of course, but well beforehand. Any thoughts? Thank you.
Thank you. That's a real big issue. We had lots of problems about communication, maybe like other countries, of course, during the pandemic. And no, during this simulation, we are focusing on the healthcare system itself, of course. We are starting from the base, actually. And but it is an issue field, and taking into consideration even here, yes, of course, because we have been damaged not only by the virus but of itself, but of the misunderstanding and the infodemics itself. Yeah, so it is a topic, not in this simulation, but it will take in account in the next one.
Yes.
Yes, partially related with communication and sharing some reflections with Martin. Could you tell us a tiny bit more, granularity about the results of the exercise? Clearly it helped into working together, but can you say a tiny bit more? There were surprises, worries, concerns, things that you needed to prioritize, invest on, or is something difficult to share in public beyond the process itself?
Maybe Michele on this topic, I don't know. You tell something about.
I tried to add something that Andrea already said. When we focus mainly on trying to find some tools that were able to make it easier to read the plan and to be more prepared. So we focused on working together to define what was the priority to put into action in the next few months, because we are working on the next to adapt, to have a new plan that is more with more preparedness elements. And to do this, we needed to share tools. We didn't want to have tools written from the top, but to build these tools from the base, from the bottom, with sharing the process, the decision-making process with the person working both at the regional level and at the local level. And another thing that I think that this exercise helped us is also to share, because we saw that during the pandemic we didn't have much time to share experience, to share best practices, to share experiences. So this opportunity to be together, all the people that worked in different cities, in different at different level, had opportunity to share what they did during the pandemic, sometimes different from one local health unit to the other, and be together in a moment where the COVID pandemic was still feeling hot, was, I think, helpful for everybody.
Yes, before we come to you, Rachel, Una, are there any questions from outside?
No questions from outside, just some reflections of that the plan is well thought of in terms of its flexibility approach and keeping in mind the views of local and regional needs. So that was really well received, but no questions from online just yet.
Okay, then we take another question from here, back there, I saw. No, there. Yes, in front of Una.
Thank you very much for that great presentation. I was wondering, it's very good to see a localized kind of simulation exercise with the local team. How did you link it up with the national level? Because this morning we were discussing about centralization, decentralization balance, and how is it accepted at the national level, and how do you link it up with? Thank you.
Okay. We had a national level simulation in January this year that was organized by the Minister of Health of Italy, and it was mainly focused on the way the networks, in case of emergency, would work and would start to put in place and to be activated. So starting from this simulation, we built our own, focusing mainly on how we are working at the more operational level in the regional health. And we try to be in a continuous with the national simulation exercise, and we had many ideas coming from that simulation to make it better or to work from what we saw doing that simulation exercise.
Rachel, do you want to take this question there from the audience?
Can I ask the question, or this from the audience, or what's the procedure?
Okay, then you go ahead.
Dr. Adam Ogalewski from the European Federation of Public Service Unions. I think it's a very important the plan you presented to us, and congratulations again. And my question is more about what we learned from the COVID pandemic in relation to social care, that we know that when it was developing in the healthcare, this connection between social care and long-term care in particular and care homes show that there is a problem here. We know from the COVID inquiry in the UK that was a big problem, that there is no one who was responsible for the social care because for the local government, not for the Ministry of Health. So was it also discussed in this preparedness for you in terms of how we could protect the vulnerable older populations in the care home? Or that's my question. Thank you.
Yeah, here in Veneto we have quite a hybrid system, which is quite different from the rest of Italy. You see every region has its own degree of liberty and autonomy in organize its services. And here there's, maybe there are more integrated sanitary and social services in comparison to other regions. Well, this was mainly focused on hospital and primary care services, as well as the governance at the regional level. But under the primary care services, and it is called district, social sanitary district here in Italy, and as well, they are the manager of the residency for elder people and other fragile patients. So yeah, they have been taken into account. Maybe not enough, okay, but we are working on that, of course, because we don't forget what happened, of course, and memory is still fresh on this topic. Yes.
Okay, before we close, Rachel, Una, are these two questions which now came in, are they worth
Yes,
reading?
we've got two questions online. Thanks, Reinhard. So the first question was, considering the simulation exercises, sometimes there's competing ideologies or priorities when we're thinking about working alongside local political leaders. And if you could reflect on some of the ways that those were considered to make the simulation exercises successful. And the second...
I just hear that the translator has difficulties in following the speed, so no, it's not particular to you, but that we should...
Slower. So in respect to the simulation exercises, in considering the agendas and priorities of local political leaders, was there a way that the creation of the exercises were considered in creating a succinct ideology or a way to make those priorities cohesive for the simulation exercise to be successful? So that was the first question. And the second question was, is it only the Veneto region or other regions also having a similar kind of simulation exercise? And if it was analyzed on a national level?
I started from the second one. No, to this day, Veneto region is the only one. Yes. Mainly the one, yes, the first one, the only one to have done this kind of exercise. We have this mechanism here in Italy when one region started something new and it actually worked, the other one follows usually. So this is our hopes actually for this kind of program. And about the first question was about political interference in this kind of simulation. No, a national healthcare system at this level, local level mainly, is quite difficult to interfere with because its workforce is quite united on a certain kind of ethics of its job. So no.
Okay, Andrea, Michelle, thank you for this really interesting presentation.
I leave it to Marco.
Yes, we now come to the second presentation, and that is the
national plan to tackle AMR, again by Michel together with Marco this time. Please go ahead.
Good afternoon, everybody. I'm Marco Milani, and I'll talk about the national plan to tackle AMR. I'm a practitioner in the Directorate Prevention, Food Safety and Veterinary in Veneto Region. Next. AMR. I suppose everybody here knows what's AMR, and that a result of drug resistance in which antibiotics and antimicrobial medicines become ineffective. And the next. But keep calm, we can stay calm because scientific research is making remarkable progress in inventing new antibiotics. Is that correct? Absolutely no. Next one. The clinical pipeline of new antimicrobials is dry. In 2019, WHO identified 32 antibiotics in clinical development that address the WHO list of priority pathogens, of which only 6 were classified as innovative. However, if people underline the word people, because it's not, I don't know if it's only an Italian problem, but in Italy we have a cultural problem that has to eradicate to change the mind of the people. People want antibiotics, and this is a cultural problem. So if people in Italy, and I know in the other state, do not change the way antibiotics are used now, will suffer the same fate as the current ones and become ineffective. Next one, so Mandel, Douglas, and Bennett's principles and practice in infectious disease, that is the, I think, the Bible of infectious disease, said, next. And although the development of antibiotic resistance may be inevitable, this is our enemy, we have our avenger, that is antimicrobial stewardship, because the rate at which it develops may be diminished by the rational use of antibiotics. It's not only a human problem, so antimicrobial resistant organisms are found in people, animals, food, plants, and environment. And AMR is a complex problem that requires a united multi-sectoral approach. This is not only a human problem, but is a problem of humanity. Next one. In fact, AMR is one of the top 10 global public health threats facing humanity. Although the number of countries that heeded the global call to develop NAPS, that is a national action plan, not when you dream in the afternoon, on AMR has reached a high level, there are some countries that even only just began to implement effective intervention to tackle AMR, and the same applies to AMR surveillance. Next. In fact, this is the antimicrobial resistance surveillance of ECDC. Then you can scan here if you want to download, if you haven't read. And I not focus in every single map, but the situation, it's not so good. Next one. In fact, public health action to tackle AMR in the EU remains insufficient. In 2020, as a direct consequence of AMR, there was the 800,000 infections and 35,000 people death for direct consequence of AMR. And when we talk about AMR, we have to talk about the healthcare associated infections, but it's not only this. Next. If we look closer, we find surveillance, research, awareness, stewardship, governance, One Health that we have just spoken, education, cooperation, training, and these are all points that are focused in the new plan, the new Italian plan of PNCAR, it's the name of the plan, that based on 6 targets, strengthen the prevention and surveillance of healthcare-associated infection, enhance the One Health approach, promote appropriate antibiotic use, support innovation and research in prevention, diagnosis, and treatment of antibiotic-resistant infection, enhance national cooperation and also international cooperation, and improve public awareness. That's the topic that I have already spoken about the Italian people. The structure of the plan. The national plan is based on 4 horizontal areas that are training, information, research, innovation, and bioethics, and national and international cooperation, and so the governance. That these 5 points are the basement of the structure of the plan. And from the basement, there are 3 vertical pillars dedicated to the interventions, the key interventions. Surveillance and monitoring, healthcare-associated infection prevention, and the appropriate use of antibiotics. What's this? It's the national plan of resilience that is next. That is the instrument that outlines the objectives, reform, and investment that Italy intends to implement through the use of European funds from Next Generation EU. Why I present this plan? Because next, a part of this plan, next, it's dedicated to healthcare-associated infection training that, next slide, perfectly fits in integration with our PNCAR. The plan in Veneto region. So we changed the N to R and became from national to regional. And this is a contextualization of the national plan that with the HIA training, next, these 2 parts has the same governance. And the governance is led by a regional technical and scientific committee made by 11 members, including university professors, infectious disease specialists, healthcare managers, and experts in clinical risk and hospital infection. And what this committee do? The group created a training project based on national guidelines and topics dedicated to experts in hospital-acquired infection in Veneto region. So there will be next a training of trainers, and these trainers are expert of infection, hospital infection, from all the hospitals, all of Veneto region, and the training placed through a combination of lessons and simulation tabletop exercises, similar to the plan that presented my colleague, but is more practical, the part of simulation, because the topics of healthcare-associated infection are disinfection, IPC, and hygiene, and microbiological screening. And the target is to train 640 trainers for the hospitals in the Veneto region by March 2024. Next one, these trainers, so experts in hospital infection designed by each hospital, starts a waterfall training. This is a waterfall on-the-job training, very, very practical, next, that has to, next part, next, okay, that has to train 22,400 hospital healthcare operators by June 2026. It's very high numbers of operators, and is the 50% of the operators in the hospital of Veneto region. So next, as small as each one's contribution may be, everyone must contribute with a piece of the puzzle. We can see PNCAR, antimicrobial resistance of ECDC, and the Global Action Plan on antimicrobial resistance. Thank you. Next one.
Yes, Marco, thank you. And we also have the opportunity to ask questions, make comments. Yes, back there. And please stand up.
My question is you to show some antibiotic program with non-specific measures. But for example, do you have some facts about, or because we have task in our summer school about, for example, mobile plasmids who can, for example, transmit for other enterobacteriales. Do you have this action plan or not?
I don't understand.
Yes. So I want to ask, do you have for some events like mobile, for example, plasmids, for example, ST23 or some other virulentic strains? Or is this only no specific program?
I don't know if I understand.
I also don't.
For resistance, for example, for topic resistant strains, it is included in your strategic plan or not?
No, I don't know if I understand, but the Italian plan, is focused on antimicrobial resistance, and in this plan are also there are other topics that are the antibiotic stewardship, so the correct use, and the healthcare associated infection. But I don't know if I understand correctly the question.
Yes, here in the middle.
Svetlana Nicolescu from the Ministry of Health, Republic of Moldova. Thank you very much for your presentation, and I think that one of the strengths of the national plan that you have presented is addressing it through the One Health approach. If I'm not wrong, you have identified a specific objective or pillar on strengthening this. If you could a bit elaborate what is the ways or models you apply in order to approach it through One Health perspective. And my second question would be, if you have established certain monitoring indicators in order to see how you progress and how do you monitor and evaluate the results under this plan. Thank you.
Okay. For the One Health approach is a part that concern the veterinary branch of our direction, and there are some indicators of this that are one named Classifarm, that is based on the antibiotic use in animals and for soil, for food, for feeding, and for breeding these animals. And for the environment, there are controlled indicator and control made by ARPAV, that is an organization, an association in the Veneto region that is dedicated to the environment, and they has some indicators that are according to ECDC and the protocol of WHO, so antibiotic use, the presence of antibiotics in environment, the presence of the antimicrobial resistance, the bacteria in the environment, and in the animal and in breeding the animals.
Up here.
The question has been partially addressed just now, which is the One Health is going to be one of the central topics of our summer school. I recall a number of years ago being in the Dutch presidency, moderating, facilitating the ministers of health, environment and agriculture together. And there were lots of differences between the EU countries and within the EU countries. So it was a fascinating exercise. So the question, two questions to you. One, are they actually environment accessory with agriculture accessory and health and social accessory working together on this area to have an aligned agenda, number one. Number two, we in the south, I come from Catalonia, from Spain, unfortunately we have the higher levels of antibiotic use. We're talking about sometimes 1/10 of what the Dutch would be prescribing. What kind of work are you doing with the proper prescribing, with your GPs, with your hospitals? Because the emphasis you put, it was an important area, which is hospital-acquired infection and quality, which is fundamental. But what about the whole area of prescription?
Maybe Michele can answer better.
Thank you for the question. Starting from the last one, in this presentation, we focused on the program, on the training program, but with the regional plan to tackle antimicrobial resistance, we are also working with the same expert that Marco said are part of the regional committee to work on guidelines on prescriptions and to identify indicators to see how single hospital are working. And one of the simulation exercise that we did was to analyze an hypothetical situation in the local health unit when we have different hospital with different prescriptions situations, and we discuss with the person participating to the training, to the simulation, to decide what were the most important things to put into place to solve the situation, to survey what the clinicians are doing, and in order to see what we can do and to the best practice and we take to a regional level. So we need to monitor from now on, because the regional plan is right now been written to a new version. So this is what we have to do in the next few months. I think we need some time to see some change in the clinician's way of prescribe antibiotics. This is of course. And another idea that we are working on is to identify a mobile app to support clinician in order to have access to guidelines, to updated guidelines. And this is something that our clinician, our infectivologists are working on in order to support not only the, let's say, the university hospital, but also the smaller hospitals in all part of Veneto region. From the other part of the question, this is something we are working, reorganizing also how we work at the regional and local level to build more connections between the environmental and health systems, because this is something that need more connections, but we are already working on it because there is a plan to make it working closer together. So this is something we are still working on at the regional level and also at the local level. But this is some part of the plan for the next years.
Yes, Rachel, Una, what did we get online?
We've got a couple questions online. So the first one is speaking more specifically to the culture of antibiotic use, and what is being considered or discussed in changing the culture of antibiotic use, more specifically, if there's any specific measures to ensure a reduction in the consumption of antimicrobial medicines, and if this is specific to, if it's a more specific task for somebody outside, like a technical or scientific group. So that's the first question that's come in.
Okay. Like I was reading the slides, there's part that's so much important, that is the awareness And the communication is a part of the preparedness and the governance of the plan. So there are some points of the plan, there are some targets that are only regarding the communication to the people, to the population, and the awareness and responsibilization of the people, and not only the sanitary operators, to the theme of antimicrobial resistance.
Thank you. The second question that came in was just more around the training program, and more specifically, how did you reach the target numbers to be trained? And if you can discuss a little bit more at length of who was trained.
I don't know if I want to respond to this. No, it's a target, it's a noble target, very difficult to reach, and we know it. So we can make everything in our force to reach this target that is very high. So we start with in the regional part, in the region part, we start with 15 I can say 10, 15 meetings, okay, meetings with these trainers, in which there are 40, 50 trainers that in waterfall training, they can cover this very high number of sanitary operators.
We take one more last question.
Good afternoon. Thank you for the very nice presentations and for your work. Your colleague before, I'm Thanos, I work for the WHO Quality of Care and Patient Safety Office in Athens. Your colleague before mentioned as well that you work with other regions and you take examples from one region from the other. So let's say that if you sit at the table with colleagues from other regions and they ask you what is the main challenge you had in this implementation and how did you overcome it, if you did?
Thank you. No, when I speak about the last presentation, it's the same region. There's not linked with our region in this moment, but the minister gave to every region the same indication, and every region can organize how they prefer the sanitary system is very strong in every region. So in something and they can organize like they prefer. So I don't know in this moment how is organized in other regions, but I know if we are the first, right? In this sense, okay. But Michele can help me.
Okay, thank you, Marco. If I had to say something that was the most challenging or most difficult thing we are facing now, this was the question, is to engage healthcare workers in practical things to do, to put in place in everyday job, because we feel that most of our workers are overwhelmed by training programs. So we are trying to think some practical situations easy to put in place in their everyday work, because they're overwhelmed with the job. So we have a short amount of time to be as practical as possible and as precise as possible to reach the goal. This is the most difficult things we are trying to face right now.
Yes. Thank you, Marco. Thank you, Michelle, for this second very interesting presentation. I think we heard two very interesting case bases here from the Veneto region. It also shows how many puzzle pieces, when we say global health security, a region has to tackle. I mean, these were only two elements out of the broader picture. We now take 20 minutes coffee break and come back here at a quarter past 5, and I then hand over to my colleagues.
So can I encourage everybody to come back in, sit down so we can get started? Can somebody look through the door there and see if anybody is yet to return? Okay, thank you and welcome to the next session of this seminar on health security, from public health to strengthening health systems, regional and national, you've heard about, and now we have the international perspectives. For those of you watching online, I'm Martin McKee, and I'm Research Director at the European Observatory on Health Systems and Policies. And I am almost joined by all of a stellar panel, with one about to arrive. So let's start with those that we have, and you have met a number of these people already. So we have Lisa Marie Volpio-Pulke, who has many roles: Senior Advisor, Strategic Affairs and Chief Medical Officer at the Finnish Ministry of Social Affairs and Health. And she is sitting beside Isabel Della Matta, who, again, those of you at the summer school have already met and heard from. And Isabel, again, is Principal Advisor, Health and Crisis Management at the Directorate General for Health and Food Safety at the European Commission. And then we have Wolfgang Philipp, who is the Head of Unit on Intelligence Gathering, Analysis and Innovation at the Health Emergency Preparedness and Response Authority, better known to all of you, and you've already heard about the organization as HERA within the European Commission. And then we have Ihor Perehenets, who is from the WHO Regional Office from Europe and is the Program Area Manager for the Health Emergencies Program. And finally, we have Christian Hagenmüller, who is from the European External Action Service and is a Senior Medical Advisor on secondment from the German Armed Forces. So, we're here to talk about crises and emergencies. And as you have already heard, crises involve the unexpected. So to try to maintain that idea of unexpectedness, nobody on the panel knows what I'm going to ask them. I don't know what I'm going to ask them either. It's going to be a voyage of discovery for all of us. But I thought it might be helpful for people in the room, people watching online, to have some idea of who to call in an emergency. So here are a group of people representing different organizations. Those of you, well, all of you, in fact, obviously come from countries that are members of WHO. Many of you come from member states of the European Union. So at some stage, you may need to ask some of these people for advice or help or support in an emergency. Now, at the minute, I'm just wondering, put up your hands if you know who you would ask for different things. Have you a clear idea as to which telephone number you would ring in a particular emergency? Hands up. Okay, we have two people, three people. We have a few people who actually know, so maybe you could come up here and go there and you can tell us, but maybe not. So what we'll do is we'll start off by asking them, so Isabel, when do I ring you? When do I call you for advice? I mean, we talk all the time anyway, but when would I be calling you as somebody in a national health ministry and saying, Isabel, what do I do?
No, you will not call me.
No, we have the alert system that is the early warning and response system, so the EWRS, that is where we receive all the notification of anything that is going on with human health. The problem is that, I mean, even if you are introducing the notification when you think that there is a problem, maybe some days have already gone, and so it's a little bit delay, a little bit. But there is always someone that is on duty. Before was Wolfgang, when he was with us in SANTE. One system that we have, and the people in Luxembourg is always on alert. Of course, you can call whoever you want. That if you call me, I will be sure that I will call Ingrid Keller, and we will call Sandra, that is the Director General, and we put everything in move. So yeah, but it's true that maybe it's not so easy. But I think, and I hope that the ones that are the responsible in the member state, the contact point, what we call the contact point, they know what they have to do. And some of them are here with us. Maybe the two that raise the hands, I don't know. But at least I hope that after this week, I mean, everybody, at least in the European Union, and also outside the European Union, you will know who to call when something happens in the human health.
So in the human health, human health. Okay, who do they call if it's animal health?
It's animal health, Paco Reviriego. So there is another system that is for animal and for food that we have. The RAS, basically, but there is also one person, and in any case, the chief veterinary officer. Through the chief veterinary officer, that they are much better organized than the chief medical officer.
And who do they call if it's a human infection going to an animal, or the other way around then?
Any of us. I mean, I will show you tomorrow how the EWRS has worked for the cats, the Polish cat, and the Finnish fur animals, and yes, and we are mobilized quite quickly.
So just to help our audience here, we have Wolfgang. You represent HERA. You've come from the Commission. Can you help us? Because I think some of us have been looking at this very complicated architecture. We've got HERA, we've got ECDC, we've got the European Commission, we've got WHO, we've got the European External Action Service. We've got, where are the boundaries? Where are the overlaps? Where are the responsibility? Where's the dividing line?
There are certain dividing lines, but there's a lot of boundaries and interlinks between the different organizations that you just mentioned. Just to come back to what you asked first, who would you call? Ideally, we would call you and tell you something is going on. If you look at COVID, for example, the early warning response system Isabel mentioned, the Commission posted the alert on the 9th of January. So to alert the member states that something is coming and something is going on, which does not mean that the member states did not have an idea, but it triggers a cooperation between the member states. We had already a legal base for that before, a lesson learned from the last pandemic, from the flu pandemic in 2010. So that health security committee, that structure, a legal base to coordinate between member states existed already before. Afterwards now, and you have heard this, that legal base has been reinforced massively to make sure that we are all on the same page and that we move into the same direction. HERA now, as a new organization, we also have a HERA board. That's not a competitive organization or group with the Health Security Committee, but it's a group where all member states are represented. So all the countries, ministries of health are represented there. And the idea is to have a board where countries can take decisions cooperatively. In case of an emergency, for example, a specific situation would chip in, and countries and the Commission would act cooperatively. There would be possibilities to screen available medical countermeasures, to list these things, to talk to industry, to produce certain things. There would be possibilities to activate budgets through the emergency support instrument, and so on and so forth. All of this all of these things are lessons learned. So there's the Health Security Committee, there's the HERA board, and both of them are cooperating with WHO in that particular situation. First of all, obviously with the Copenhagen office, but the most important is that we have the right links with the decision makers in the ministries of health in the first instance, and then afterwards in larger groups to move on into the same direction. So the call would be through these established structures from the member state side or from the Commission side as well through these established structures. And ideally, we would all let's say, first of all, come up with a good match plan and then implement it. So that is the reaction that would be created.
Now, I realize that we can't comment on individual member states, but you call up a member state, and what happens if nobody answers the phone? Or they say, we're busy, we've got an election, we're in the middle of an election campaign, or our Prime Minister's just done something or other. What happens then? Because I think this legal responsibility, the legal powers, are really an interesting one. You can have powers, the police have powers to do all sorts of things, but they may not actually be able to do them. So I'm just interested in what happens if you've got a member state that is not cooperating.
I think that would be, for these upcoming elections, for example, would be very bad in terms of outcome, because if you have 26 member states moving into a certain direction, and one says that does not concern us, because we're talking here about cross-border health threats, so it's not regional, it could also be regional events. In that case, really, it's a very theoretical scenario, I would say, although we don't have power to enforce any kind of reaction, but we have seen it in this pandemic and also in the pandemics before, in particular in this pandemics, that there was a strong will and also a good way of cooperating on certain fronts, like for example, joint procurements for tests, for PPE, for drugs. That is all what we have done in the first couple of months with all of the member states, plus a couple of neighboring countries. The vaccine strategy is a good example, where member states really work together relatively quickly and ensure that access to medicines are there. In the Health Security Committee, believe it or not, we have, it was not just a debating club. We really agreed on certain elements, like, for example, minimum elements on how vaccination strategies should look like, and put this on paper. So there is a good will from all member states to really cooperate, because it might be essential to survive the next couple of months and not just the next elections.
And it might be a question for you or for Isabel or for anybody. When will we get a synchronized, coordinated vaccination schedule for childhood illnesses in Europe with everybody using the same timetable?
Never. I mean, request the countries that have regions here. For example, my own country, Spain, there are 17 different vaccination calendars. I mean, all the regions and all the countries will always tell you that the epidemiological specificities of the children of your country, your region, your town, your neighborhood makes that whatever. So, no.
So the vaccines work differently in somebody from Catalonia than from Extremadura, or differently from somebody in Finland and Germany?
What we try to get is that all the countries, if possible, but well, is what we are trying, is that they have the same vaccines and the same number of doses, but the exact time when they are having that is because will be very difficult to have.
Please, Wolfgang.
I mean, I know that question, and I knew that was coming up at one point. But I think we should go to the end point. What exactly do you need to have a good vaccination rate in certain settings? And that is very different. I think it's a matter of fact. Even during the COVID pandemic, the recommendations for vaccination were different in different countries, because you had a different epidemiological situation, you had a different uptake, you had different kind of, let's say, resistance or resistance to it, and so on and so forth. I think that is best done really at levels where you have the data and the underlying evidence. And that is, for example, why we did in the Health Security Committee, we did not say we are going to develop a vaccination strategy for all countries and that should be implemented. We said these are the minimum elements that should be taken up and should be considered for your vaccination campaign when in 2 months later the vaccines would be coming in, so that the member states were really prepared. So I think looking at the endpoint is the first exercise here.
But a big question, because there are some countries that have been very reluctant to vaccinate children, even though we know that it is the COVID vaccine is safe and effective in that group. So you talked about working with neighboring countries. So Ihor, this is where you come in, because we know, I mean, the cliche, microorganisms do not respect borders, and it's an issue that you presumably can help with, because you cover a number of the countries that go beyond the borders that Wolfgang and Isabel are dealing with. How does that work, particularly when you've got all this expertise here, but then in some of the neighboring countries, you don't?
Yeah, thank you, Martin, and thank you, Isabel, for framing the discussion by saying, by suggesting referring to the EWS, because that's actually a very good starting point. But also, I would like to acknowledge that in this room we have mostly EU member states, but also we have 4 non-EU, at least as that I noted from the list: Ukraine, Moldova, Serbia, and Tajikistan.
And the UK.
And the UK, yes. Joined the club of non-EU member states just recently. Voluntarily.
They share a lot of characteristics.
Right, 5, yes. So, and then, we actually, the question that you asked, Martin, like, where do we call? So, if we have to call somewhere, that means that we, as the country, for example, or as the public health system, did a good job in surveillance, and we identify something that was notifying, right? Notifying the region or the neighboring countries. And for this, in order to notify the risks and to share the information about the risks, we have to say that globally speaking, or let's put it regionally speaking, we are quite well prepared to assess and notify the risks, because in the EU member states, there is an EWS system, but when it comes to the broader perspective, the WHO Euro member states, which is 53 member states, state party to the IHR, we also have the IHR system that is, again, referring to questions, is mandatory. And what if you are not reaching a responsible person? You're supposed to, because the IHR focal points, and this is not a person, it's a function, supposed to be accessible 24/7. So there is no such a thing, or it's not supposed to be such a thing, that you cannot reach a national IHR focal point unless this is really one person, which is a case in many countries, and this is not a good thing. So then the IHR focal points that receive the information from the surveillance system, from the public health services, and evaluating it, that this works of informing the WHO or the SANTE, they enter this data through their own, not their own, but the established system, EWS, or IHR focal points communication like to the WHO Euro, for example. And for example, if the EWS information is shared, WHO sees this information because there is a box that ticks that information goes to the WHO. And if the WHO receives the information from non-EU member states, this information is also available for the rest of the region, of course. So we do not have problems with the risk identification to extend information sharing between the member states. But the problem starts when we have to respond to the risk that is identified either by a single country response or by cross-border risk reduction approach when a number of the countries can be affected. And this is what is one of the learnings from the COVID response, when our sovereignty to extent resulted in the response modalities when it came to have the single country response or multi-country responses, which affected the overall the spread of the disease, the speed of the spreading, and the response after all. And then the question of vaccine arrived much later when we understood what is happening actually.
So, but it's not just, of course, the relationships within the European region, but you have on your border the African region, the Eastern Mediterranean region, the Western Pacific region, all of those challenges. And you've recently, the regional director has been crossing the border into EMRO actually with the earthquake on the Turkish-Syrian border. You've even got the relationship with PAHO, Pan American Health Organization, in the Arctic not that there are that many people there, but for zoonotic infections in polar bears or whatever. So how does that, can you just, because people might be interested in how that works, and linked to that, what you do about the holes in the system. I'm thinking about the bits of land that are not within this, northern Cyprus, Nagorno-Karabakh, and we have somebody from Moldova here, Transnistria, for example, how those systems work. And anybody can answer them because it's not an easy question.
Right, so you have two questions in one, basically, right?
Yeah.
So one thing is when we know that a neighboring country that does not belong to our region may suffer from the consequences of, for example, an outbreak, local outbreak in our region. Of course, this information goes through the, again, IHR, a focal point information line, and then when it arrives to the regional level evaluates the risk, do the rapid assessments, and understands whether to inform the neighboring region about the possible spillover effect from this country to another country. Like, we have this communication constantly with, for example, our Central Asian countries, and colleagues from Tajikistan can confirm when something happens, for example, Afghanistan has to be engaged, and then we go to the region focal points and talk about it. When it comes to the disputed territories, let's put it that way, right, that are recognized by or are managed by the de facto authorities, but legally speaking, belong to different countries. That's, of course, the global challenge. This is nothing new for the regional level. Unfortunately, the Euro region gets more these type of territories, right? And you know which one I'm talking about, being a Ukrainian. But the rest of the globe is facing the same challenge. And this is where, from what side the support should come, how this support can be delivered, and so on. So that's, we will go into the politics right now.
And if somebody really wants to get into pub quiz trivia, looking at the borders in Central Asia is absolutely fascinating, because when they were drawn by Stalin in 1928, there were lots of bits that were disconnected, and there are enclaves and exclaves, which are enclaves inside the exclaves, and it can be incredibly peculiar, but you have to deal with that. So, Christian, you're coming to this from a slightly different perspective. You've spent much of your time on ships in the Navy, and suddenly you're having to deal with all of this. And you were telling me earlier about your time on submarines and fascinating things, but submarines are small communities. There's all of this complexity. When you came to this, what are the things that surprised you? Or did anything surprise you?
Well, so I spent a decent time in ships, yes, but there was a phase when from the ship until coming here, I was very long time dealing with a NATO or specific NATO unit that was collecting lessons learned. And one of the major topics that I was dealing with was just how the military was contributing in complex emergency to the medical healthcare endeavor, so civil and military. And this is, and I have done it over almost 10 years. So I have a certain understanding what the civilian are doing in a health crisis and what the military is doing. And this is, there is a huge overlap, absolutely a huge overlap, and also I need to clarify that kind of overlap. And this is what brings me specifically here to articulate that kind of common interest in that twilight zone, but also the different capabilities there are. And I really liked your question. That was, I think, one of my main questions when I arrived to the European Union. That was last September. And I was, okay, if something really happened, a crisis occurred like this, who do I call? And I'm the military medical advisor to the External Action Service, which is the diplomatic service of the EU. So I should be ready to provide that answer. And I was struggling. So I really said, you hit the point with that. Because still now, I'm still how it works is we know there is a system, but what works best is, and that tops everything, is personal relationship. So once you have a personal relationship to that and that institution, then you can navigate much faster, because they will tell you, oh, listen, I'm not the right person, but I will take your question, and I will proceed with that. So I think that was a very good one, and you would call, let's say, the military, if my colleagues here on this table would not provide you that kind of answer that you are satisfied. So, for example, do you have add-on information? Do you have add-on capabilities that the others haven't provided yet? But definitely, for sure, the military is, in an epidemic situation, just lean back, and we are just the second or third row.
And what can you specifically offer? I mean, obviously it depends on what the emergency is. If you are being invaded by a neighboring country, you want tanks, obviously. But if you have an earthquake, you might want something else. If you have a pandemic, you will want something else. So what are the sort of, what is your menu that other countries, that people can ask?
So just a couple of weeks ago, there was a lessons learned conference by the Military Medical Center of Excellence in Budapest. NATO countries, and it was really about what the military was doing during that COVID pandemic. And it was interesting that every nation had different, so there is no one answer for every nation that fits for all. So every nation came up with a different set of capabilities that they were doing. For example, one was just, they provided the whole logistics from getting the vaccines from A to B. The others, they were just doing the vaccination, providing access healthcare facilities just in field hospitals. But also there was areas where some, let's say, information, you needed to get some validation of specific information. And we have some missions in Africa, for example, and there we have also our own healthcare system, our own diagnostic. And so we have some insights how it works in that particular area. So, and this is something that is complementing to that what the WHO has already in their regional offices. And there are things that are matching, and there are things that are contradicting.
Do you think that, sorry, I'll come to Lisa Marie in a minute, but do you think that people are sufficiently aware of what you can offer? I mean, I've just got in my mind, we were talking at lunchtime, and I've got other connections, and I saw a very good example of where the British Armed Forces have deployed troops, a small group in northern Cameroon on game on wildlife protection. And there you've got relatively junior combat medical technicians with very sophisticated equipment, with goggles that can transmit in real time to a doctor, interestingly, in my home city in Belfast, that can guide them to actually do the procedures in real time. And I'm just wondering, some of the things that you're doing, is there enough awareness of that in the wider population, in the civilian side?
I will talk about that, probably also I will touch that on first.
Okay.
But just to say, there is a lot of development, innovation within the military medicine endeavor that might be quite interesting for the civilians to understand, to see. For example, telehealth, so remote diagnostic and transmitting of the whole, let's say, medical information. Then we were just later, before we were talking about AMR. So one of our research field is phage therapy, for example, extremely important for military medicine, because AMR is a huge problem for us. So there are many other areas where we really are doing something complementary, not always cutting edge, because the new civilian biotech services, they are so far ahead, but there is a kind of validation and testing that is, I guess, quite important for the mainstream healthcare providers to see, okay, if this is vetted by the military, then it might be also good for our society.
So, Lisa Maria, you're from Finland. Now, Finland is a country with a very strong public health tradition, with some very high level of excellence. I know because I've been on the external evaluation program for Tampere University, for the University of Helsinki, Academy of Finland at various stages. I've seen the excellence of the work. Why would you need to go to any of these people? Don't you have enough expertise yourself? And is there anybody else you would go to?
Oh, no, of course. We're talking about health security threats, and they are global by nature to begin with. And in that respect, I think that international order is the safety net for a small country like Finland. Threats don't respect borders. That's the starting point. The question is, whom would I call? But before I would call anybody, I would sit down and think for a moment. My number one question would be, if I knew something about very vague information, weak signal, is this going to be a political issue within hours or overnight? Do I need to inform my minister? That's my number one responsibility. Number two, is this information already public domain or is it not? Because that has an impact on how I should alert our media persons at the ministry. Number three, does this fall in the mandate of the European Union? These are the three basic questions. And since I've been called a chief medical officer, which is not an official position in Finland, I'm not alone at the ministry. I need to rely on colleagues. And talking about whom I would call, actually, I would first call my health attaché in Brussels, if this would be an EU issue, a potential EU issue. Then I would call my colleague at THL, because THL speaks to ECDC.
Just explain who THL is.
That is the National Public Health Institute, to make it simple explanation, because they talk to ECDC constantly. And probably through these unofficial networks, there would be already much more information that I would officially be able to get. They already are a little bit ahead of issues. And finally, I would call my colleagues at the ministry and ask for advice, whom we should actually contact, because I'm not that expert who would tell which one of these organizations and who in any of those would be the best contact right now. So that is sort of how I, as a civil servant, being for example, the Director General for Strategy, advising the ministers and the Permanent Secretary, how I would act in such a situation. Sorry, that was a little bit different.
No, it's perfectly fine. So you would get a lot of advice from within Finland before you would actually go anywhere else, because that will be a challenge for some of the other countries that are very small. Well, maybe it might be easier, it might be more difficult. Christian was talking about trust and personal relationships, and you and I have discussed this before. I'm convinced that one of the reasons Finland was so successful was that everybody does know one another. And because you have rehearsed a potential crisis related to your rather large eastern neighbour on a regular basis, and you know who is good, who's maybe not so good, you've got the mobile phone numbers and so on. Are there lessons for other countries there?
Well, this is my personal experience. I think that, okay, as long as things go well, and as long as people know each other and respect each other, it works. But in case people have very divergent opinions, they come from different political backgrounds, and everything gets politicized, you need a legal background. You need infrastructures that keep the machinery running, even if people would be failing.
Yeah, and maybe you may or may not want to share any particular Finnish experiences. Maybe we'll move rapidly on, because I know that there may, like in every country, there have been a number of challenges. Wolfgang, I want to come back to you and HERA. One of the main roles of HERA is procurement, and procurement is difficult. I mean, at one level, you go and buy things, but of course the challenge is that the things that you might want to buy, you don't just pop down to IKEA. Well, you could, but they won't have them necessarily. So can you just tell us about the challenges that you face in public procurement of the things that you want, and the implications that there are for the people here in the room, because they are going to be dependent on you getting the procurement right. Can they help? Do they get in the way? How does it work?
So just to rectify one point, I mean, we are not a procurement agency. HERA was really particularly set up as an end-to-end agency, so that starts from the signal, from the intelligence, because you have seen during the pandemic that was a problem. I mean, everybody turned to, not everybody, but at certain points you had to turn to sources which were not, let's say, EU-based, to say it politically correct. Second thing is, from that intelligence, we do assessments of a potential threat. So is it something local, regional? Is it something we can forget about? Or how is it going to develop? And then we look into the availability of medical countermeasures. So the point you're referring to, is there anything or nothing? So that is either in a situation or in terms of threat assessments which are run in a dry run or coming out of exercises. In that case, we would invest into research first. So research and development of medical countermeasures. So that could be on vaccines, drugs, diagnostics, everything you might need in a particular situation that could become a public health emergency. And then we would start looking into procurement. So we also have procurement specialists that know how to do these things. And then at the end of the day, something not to forget is the deployment of these medical countermeasures. So vaccines is only one thing, but when it comes to last year, we had the monkeypox vaccines, for example, how to deploy these monkeypox vaccines, which were not available, let's say, in huge amounts, in a way that we help the member states or those countries that need them to really get their events under control faster than normal. So these are all the points that HERA is dealing with. When it comes to procurement, if things are available, we would run a procurement as quickly as possible. We have good connections with industry, so that is set up regularly. We have a joint industrial cooperation forum, for example, where we discuss with industry as well about certain elements that need to be procured. Certain medical countermeasures need to be procured. If they're available, what are the lead times, and so on and so forth, that you know about it. The second thing is, and that's the main activity now since HERA was established about 2 years ago, 1.5 years ago, is the establishment of stockpiles of medical countermeasures. So we have been spending, or we are spending about 1.3 billion euros now in this 1.5 years on medical countermeasures, which should be stockpiled and which should be available in case of an emergency. Might it be public health emergency, regional, whatever kind of level it would hit. So here we're looking really at the most essential items available. But most of the investments from our side really go into either research, so through the Horizon Europe program, with 1.7 billion over the 6 years, where we really focus on vaccines, but also on drugs, like, for example, broadband antivirals, which is a big thing at the moment, or smarter diagnostics, which is also a big thing at the moment, as well as on vaccines, so basic stuff. But we also invest quite a lot through the health, through the EU for Health program, 2.7 billion in 6 years, and some of that goes into the development of late-stage developed products that could be used as medical countermeasures. So we do some procurement. We have money for it. It has started. Stockpiles are being established now by the member states. paid by the Commission, but by the member states, and will be available then as from a couple of months onwards now.
And the stockpiles need to be rotated. So it's a bit early yet, but do you envisage any problems with that? Because that was certainly a problem in the UK. The stockpiles were there, but were not rotated.
Yeah, in other countries, stockpiles were there just a couple of months before the pandemic started. But the rotation is obviously, you need to have a look at each single medical countermeasure to see what needs to be there physically or virtually, where you need just reservation contracts, and what can be rotated through normal consumption in the healthcare sector, but that needs to be replenished as well. So, but that will be done. We are working at the moment on a stockpile strategy in a bigger context, in the context of strategic autonomy, basically, for critical medicines as well. So that is being done at the moment.
So I said procurement is difficult, and I was the rapporteur on the expert panel report on public procurement for SANTE and Isabel and her colleagues. Military procurement has got a long, you've been buying, not you personally, but governments have been buying very expensive equipment for a long time, and it hasn't always gone well. And one of my former PhD students now working in the Commission was looking at hospital procurement, and we used as an example the British aircraft carriers, which everything that could have gone wrong did go wrong and continues to go wrong. And so I just wondered, do you two talk to each other? Do you compare notes on procurement for HERA, military procurement? Because there's an analogy with buying tanks and aircraft carriers and armored fighting vehicles that make everybody deaf, to think of another example.
No, absolutely. I mean, it's not that we are procuring together.
No, I'm not suggesting you should do.
But I mean, obviously we are looking with colleagues in NATO in particular, with Christian and the EAS. We are looking at what is essential and what is going to be bought, in the future, and what kind of quantities are being taken up. There are different needs on the military side. No, but I mean, there's a good overlap on many of these items. But the exchange is there in a very active form, in particular in the context between the Commission and NATO.
So, Ihor, where does WHO come in? We talked about the research that Wolfgang is doing, the stuff that you're doing on rapid diagnostics in the field, that sort of thing. Where do you get your expertise within WHO on innovations in rapid diagnostics for infections and things? We saw a revolution with the lateral flow test for COVID. Everybody here basically had a virology laboratory in their kitchen drawer. And where do you get your advice from?
Well, when it comes to the medical countermeasures, as we call it, or more specifically for the innovative diagnostics, or treatment, for example, and again, we all remember the COVID situation when new drugs became available and new diagnostic had to be created, not necessarily from the scratch, right? Because some developments were happening after first SARS outbreaks years before. In the WHO, the domain of the research and science is hosted by the HQ, where the group of the scientists are evaluating all the different entries that are submitted to the WHO by the basically R&D sector or the producers that claim that this and that product is efficient against this or that, if we talk about the specific agents or health conditions. And this is where the decisions are made based on the scientifically available data, trials, and evidences. That's more or less like the industry does when they do studies on the efficiency and effectiveness of specific agents. And then the WHO pre-qualification program is one of the more obvious example, for example, and more clear for the member states. But it relates to, for example, the current and previous situation with HIV and TB and malaria, for example, right? When the specific drugs were pre-qualified by the WHO for the countries that cannot afford or do not have capacities to ensure quality and safety of specific products. So WHO pre-qualifies, that means that the governments can take it and believe that WHO did a good job by saying, this is good to use, right? But that's another dimension of it. When it comes to what Wolfgang mentioned about how the HERA will be stockpiling and planning. So I believe a fundamental factor to understand what to procure or to stockpile is to understand for what, right? We are in Venice, and for example, the perceived risk of vulnerabilities, looking for the water, for example, are totally different than the cities 20 kilometers from here. So they are vulnerable for some hazards that are unique for this place. That means that I'm sure that Venice has a stockpile of life jackets, of boats, or something that needs to be responded when the water will come up, or of course the infection hazards as well. So understanding your risks and your vulnerabilities based on the data analysis surveillance will help you to prepare by stockpiling certain medical countermeasures. Were we prepared enough for the COVID? Well, we were, but not enough. But we cannot say we're completely not prepared. We were prepared, but at the global scale, the distribution or positioning of some stockpiles of certain medical countermeasures were concentrating in one place and was difficult to deliver to another place. And that's why one of the reasons why HERA became as part of the new EU health security framework to ensure that, as Wolfgang said, end-to-end, from R&D to delivery, everything is available.
Did you want to come in, Wolfgang? Because I want to bring Isabel in, but please.
A very slight addition for the purpose of being complete. So stockpiling at EU level, which is done at the moment through HERA, that is not an EU-wide stockpile. Right. This last resort stockpiles for essential things, antibiotics to antivirals to even PPE. No? So that is one thing. And the other thing we should not forget is the joint procurement, because you asked about about procurement. Yeah. Joint procurement, that is something that happened and that worked also during the pandemic, not just for the vaccines, but as I said, I mean, we did huge contracts, huge framework contracts in the first couple of months for everything that was needed. Obviously, the market situation was very difficult, but on the other hand, what we achieved is, or what was offered was access for 37 countries to these joint procurements. And some of these framework contracts were used really widely. So what we're doing at the moment at HERA is lesson learned out of these situations, but it's last resort, and it should be complementary to what many member states are doing at the moment, and since the past couple of months, to establish their own stockpiles. But they should be complementary, and they should be flexible in a way that we don't waste any resources and create any kind of artificial competition.
And of course, you can procure quite a lot within the EU, but as Isabel was saying earlier, during the pandemic, you suddenly found that the precursors for medicines like paracetamol were being made in Wuhan or some other place that you couldn't actually get them. So I'm just working out, you know, the Observatory has got the book, Everything You Wanted to Know About the EU, but we're afraid to ask. It is a great guide, but of course the difficulty is that many of these issues impinge on trade policy, on external relations, and so on. So where is your role in SANTE in supporting supply chain security? How do you contribute to that? What dialogues do you get into, or does it take place somewhere else?
Well, we have the global health strategy that was approved just at the end of last year. It's something, well, that we have, it's new, we have developed, but before we were already working in all the different groups. I mean, we work with WHO, we work with the G20, G7, I mean, all the different institutions. Depending of what is needed in a moment or in another. So we are well aware that we are not alone in the work, and that we need to collaborate. For example, for the supply chains, or etc., we also collaborate with other general directorates of the Commission that are in charge of dealing with the different companies. We have just presented the new pharmaceutical strategy that now has gone to the Council and to the Parliament. And one of the objectives is also to try to increase the production in the European Union. We also are working in what we call the the foreign direct investment. So making sure that our companies are not bought by third countries that, will be using or will be destroying them. So in order to guarantee the supply in the European Union. So everything is broad. And also, one thing that Ior mentioned before, and regarding to the other parts of the world, remember that some of the European Union countries have territories that are outside the European Union, and that they also report to us through the EWRS, and we report to the WHO, of course, and to the different regions where those territories are.
Indeed they are. And a question for the audience. Who would like to tell me which is the furthest part of the European Union from Brussels? London. London in terms of cognitive, yeah, okay, fair. I'll accept that one. Geographically, not in temporally. Geographically, who would like to tell me where is the furthest part of the European Union from Brussels? Further, French Guiana, close, but not quite, and of course it is on the Euro notes. Actually, La Réunion, because it is a département outre-mer, as opposed to the French territoires outre-mer, where President Macron, as I'm sure you're all aware, is visiting as we speak in New Caledonia, and I'm not sure if he's going to Wallis and Fortuna, but he's certainly, I know, in New Caledonia. So that's an important point, because a number of the European countries do have territories outside the Netherlands, obviously, in the Caribbean, and France in particular. So, and Spain, of course, has got two little bits on Ceuta and Melilla as well.
Don't mention that, please. We'll go for a war.
Okay. Well, Gibraltar's outside the EU now, but as you know, that's a very hot topic depending on what happens with the election in Spain. But I'm not going to ask any of you to comment on that, because somehow or other the British government forgot to sign an agreement about Gibraltar, but you know, that happens. Anyway, enough of these things. What I'm now going to do is say, who has got questions from the audience? And maybe we have any from online, Una and Rachel. So let's take the online ones first. Anybody online?
So we've got a very targeted question from a member from Serbia. So Serbia has approved the vaccination of all foreign citizens with every available vaccine against COVID-19, as well as for citizens of Serbia. Has the EU shown this kind of solidarity with other non-EU countries? Can the HERA system help our citizens and the health system?
So just to clarify that question, do they mean that I'm not quite sure I get the question, or maybe somebody else does. What are they asking for?
Has there been a show of solidarity from other EU member states to open up vaccinations for all residents or all peoples who are living within the country?
Okay.
And can HERA support this?
Yeah, so who would like to comment on that?
I mean, to my knowledge, which might be incomplete, at least most EU countries had the same system for residents.
Yeah, I think
they could simply go for vaccination with COVID.
There was an issue, of course, with countries like Hungary using Sinopharm, and then that not being accepted for vaccine passports and so on. I think that maybe, but that was what I thought they might be referring to. But I think the general principle is, as you say, anybody that is a resident
already for your own protection,
for our own protection, because.
May I add, who would show up?
Who would show up?
Yeah, at the vaccination center. At some point, we reached that level that we didn't ask for any nationality or residential rights.
But that does raise a point that I made earlier on about data on ethnicity, because, as you know, I can be quite critical of the UK, but at least in the UK, we have very good data on vaccine uptake by ethnicity. And so therefore we can identify ethnic groups and the languages that they speak to ensure that we have targeted campaigns which will address their particular issues. If they are Somali, for example, or from somewhere else that might have a particular issue about vaccines, particularly because there have been politicians who have been spreading disinformation among those groups. as is happening in the United States with the African American population, where some of the extreme Republicans have been spreading disinformation among the African American population. And that's a challenge, I think. Anybody like to comment on that? Because in pretty well all of Europe, we don't collect those data. Wolfgang or Isabel?
I think that's it's a very important point, and again, one of the lessons learned. Some countries were doing it, also in the European Union. I mean, the UK did a very good job on this. Yeah. But I mean, I'm also quoting Denmark. I mean, that's the standard. It's easy to collect. It is easy to link to other data which are relevant, to also trigger and to direct your vaccination campaigns. That is the purpose of it. It's not collecting data. It's to run your vaccination campaigns in a way that you decrease the damage that you might face otherwise.
Because if your information is not available in, take it Somali or Hausa or Yoruba or whatever, then there are going to be significant numbers of people who will not have access to it, isn't it?
No, but there has been always a significant difference between the UK and the rest of the European Union, on the continental Europe, in collecting those data. For us, for almost all of the other countries, not all of them, but almost all, is forbidden to collect that information. It's the only the UK that has that obsession to collect white, non-British, non-Irish in the COVID campaign. What my daughter had, for example, and my daughter is like white, red, and full of freckles. So I mean, but to make clear that she was not British.
And of course, many of us have multiple identities.
What we really collect are other data that could give us this kind of information, like the neighborhood, for example, that many times they are, some population group are more prevalent in some neighborhood. Another data, but the ethnicity, the race, and others. Well, we are doing some work on that, but in many countries, I insist, is forbidden. It's forbidden by law.
And forbidden because of historical reasons going back to the 1930s, because of the abuse of data linked at that time to religion primarily.
Second World War.
Yeah, exactly, to the 1930s. Did you want to come in that, Lisa Marie? No, okay. Other questions online?
Got a few. Do you want me to give them
Please.
all together or one at a time?
Well, let's take them one at a time anyway.
Okay.
And then other people can wave when they have questions from the floor here.
Okay, so following on from that last question from Serbia, how will the Health Security Committee and HERA coordinate with and support non-EU countries on health security issues?
Well, that's a question for you two, I think. And maybe for you also, Igor.
The Health Security Committee, in principle, is composed by the EU member states, but and has some observers. During a specific situation linked to pandemic or a specific public health emergencies, we allow the access to some countries, to the EWRS and also to the Health Security Committee. That has been the case of Switzerland, for example, and for the candidate countries, this is like that. So, and WHO is always, and NATO, and the EU military service. So, one thing that we differentiate clearly is the peacetime and the wartime, the crisis time when things. We invite everybody that has something to say, and that is not only for those countries; it's also for ourselves. We cannot allow to have bordering countries and not to know what is happening there. So yes, we really coordinate.
But HERA is also involved outside Europe. I think something with Senegal recently. Did I hear?
Yeah, I mean, so what we're doing is we support also projects outside of Europe, in particular when it comes to intelligence gathering, when it comes to running clinical trials and that kind of thing. So I think that is one point. But specifically now on the regarding the question, the HERA board, or let's say in a public health emergency, it would be the crisis board. The crisis board would be composed of the commissioner or commission president and executives from countries, so from all member states. They would take a decision what to buy, how to act in terms of availability of medical countermeasures. And then referring very specifically to what we have seen during the COVID pandemic is that many of the countries, adjacent countries, also got access to the vaccines, for example, through donations. That was done centrally.
Moldova is a good example.
Europe, also bilateral donations were running from very early onwards. So I think that we would see the same kind of solidarity spirits also in a future public health emergency.
Yeah, I just can add from the WHO side that and confirm, yes, that many instruments that EU established for the EU member states, they are available for the non-EU member states when it's needed. For example, for public health emergencies or the emergencies that result in the public health risks or emergencies like Isabel mentioned EWRS, Moldova and Ukraine got access to the EWRS only because EU start accepting Ukrainian patients and the information has to be channeled through the EWRS, for example, right? The projects, yes, and we also, as a WHO, happy to support the projects and implement the project that cover non-EU member states. So I believe this is one of the way of sharing knowledge, technologies, and approaches that, especially for the candidate countries, is very useful, of course, and WHO is happy to be part of this.
Now, Joseph would be disappointed if I didn't make this point. Of course, it also depends on the third country wanting to cooperate. And some of you will know that within an hour of the UK and the EU signing the Windsor Framework to sort out the issues in Northern Ireland, Ursula von der Leyen said, "This is great, we can welcome the UK into the Horizon Europe programme." And months later, we are still waiting for the British Prime Minister to decide that he actually wants to join, even though every British scientist wants to. But I'll just mention that in passing because I would be a disappointment if I didn't. Right, Eamon.
Yeah, thank you. Eamon O'More, I'm the Director of National Health Protection in the Republic of Ireland. And to build the theme, cooperation with non-EU states is a matter of everyday health security cooperation for us in the island of Ireland, where we closely collaborate with our UK neighbours who share the island with us. And we have a long history of collaboration, a number of different programmes, and that continues. And Christian, you made the point that actually the personal relationships are sometimes the most valuable asset at a time of crisis, and I would certainly recognize that, having worked for many years in the UK myself. My relationships with my UK partners are very much based on that, professional and personal. But I think it's very important that we continue to build those relationships with UK and other non-EU members, because our collective health security depends on it. And bilateral arrangements or multilateral arrangements to share health intelligence, health preparedness, and so on are really in everyone's interest. So I think for us, we need to recognize the challenges, but move beyond them to create a better health security arrangement for the whole of the EU and beyond. Thank you.
I'm guessing everybody would agree with that. Other questions from the room or from further afield? Una, did you have another one?
Yeah.
And then here after.
Yeah,
Go
so we've had a comment from the National Health Protection Service in Ireland that it's a challenge to maintain systems built during COVID-19 and repurpose them to an all hazards platform to be prepared to respond to future shocks. How does WHO and the EU see their role in supporting best practice for preparedness and response at national level within countries?
Okay, as they asked first WHO, but okay. I mean, we have several mechanisms for sharing best practices, not only through the Health Security Committee, but also through the Public Health Group that we just created, that has, currently address communicable and also non-communicable diseases. And one of the mechanisms also to share best practices is with the EU for Health Programme and the joint actions. The joint action that is one mechanism that is not common to other programs, to the Horizon or others. Is not a procurement, it's not a call for proposal, it's one mechanism where the member states go together to develop one specific area. And with the funding from the EU for Health, they decide who is the coordinator, who are the practices to be shared. So this is one of the easiest mechanisms, but also through the different subgroups of the Health Security Committee is where we are doing that. At this moment, there is no 1 week where we don't have a meeting of the Health Security Committee on different areas, on different issues. Tomorrow there will be one. Last Friday there was another one. So in specific topics that are of interest for anyone.
Okay. Yeah. Okay. Hello, everyone. I would like to say. Yes, my name is Verica Jovanovic. I'm coming from Serbia, and we met already during these sessions, these first 2 days. Okay, thank you. Thank you. And I would like, to say that you cover very well these important topics, actually, and it was really a privilege to listen every one of you. I would like, to mention 2 things that are interesting for me and for a non-EU country, because I come from Serbia, and there is a team that also come together with me, but there are many other colleagues from other countries. And then I think it is very interesting from the perspective of non-EU countries to have some information, and that's why I congratulate to you for the chosen topics for this school, because I think it is important for all of us, but also for people that are coming from EU network and countries. I would like, to mention 2 things that actually was mentioned by Mr. Eichhorn. During the COVID pandemic in our country, we had a very strong usage of IHR channel. And it was really very good strategy that linked people and countries. And then it was a good instrument for the early warnings about the emergency. So I think that something like this kind of channel, as we know, there is a EWRS system also for emergency detection and information. I think that we should maybe somehow do the promotion of ad hoc health security committee where this EWRSC could be also available for other regions, because there is no security for that. And the other thing, if you can say a few things about the HERA system, because it's very important mechanism for the procurement, and I think maybe there is opportunity to have information about the program of HERA procurement system at annual basis, maybe from now on. Thank you.
And of course, there is a HERA work plan published every year, which I would commend to you. You can read it. And anybody want to respond to that? We are getting close to time.
For participation of third countries in our mechanism, there is a legal issue, and that is that we collaborate with all the countries in the world, but participating in our mechanism is for the countries that are part of our institutions, so of the European Union. So this is we have been discussing for many years. We try to incorporate the candidate countries when they have already transposed part of the legislation that applies to those mechanisms, and we collaborate with the EEA countries, so Norway, Iceland, and Liechtenstein. But in some cases, and here I insist, it's a legal issue, a strong mechanism. But when there is for Ebola, for COVID, for tuberculosis that I remember in 2014, or etc., we have been incorporating those countries, and now Ukraine and Moldova, as Igor has mentioned. So
that's exactly what Martin, thank you. Answering for the previous question, and then we'll come back to for a colleague from Serbia. Well, all the countries responded to recent public health emergency in their own way. Only one country in WHO Euro region maintains the logic that they do not have COVID up until today, right? I will not name the country, but you probably know which one. right? But all the countries responded to COVID, meaning that all the countries have some capacities to extend to respond. To what extent, that's the question of the capacities of your own countries, of your own institutes, and so on. And the WHO is happy to help with that. One of the answers to this dilemma or this question, what to maintain, because yes, you're right, countries developed a lot of approaches, a lot of useful instruments that we learn collectively. As a WHO, as the member states, we all learned many things. And as Monti Commission, for example, suggested, and they start drafting the report before even COVID, at the beginning of the COVID, and the WHO now took it as the flagship initiative with the Hans and the regional director leadership on creating a pan-European network for disease control institutions. It does not mean that this is only for the public health institutes. It covers many other entities that can be collectively organized in the network of the networks. And the first meeting of the steering committee of this network will be held in Istanbul shortly, where we have the regional emergency preparedness capacity building center. So this is one thing that I would like to acknowledge. Monti Commission and Pan-European Network of Disease Control Institutions. The second one, we just recently published the COVID transition plan. And in this COVID transition plan, you can find many mechanisms and approaches that your country actually developed and implemented. And again, it's up to the country to maintain what is needed. And we do acknowledge the issues that when you invested so much time, effort, and resources to create some approaches and mechanisms to sunset or reduce many of them is sometimes can be even a political challenge. But that's, again, that's a matter of our collective thinking through the networks that we as a WHO will facilitate, and with, of course, with the coordination with EU and engagement with the EU partners. And
yeah. Okay, we have run out of time, so what I'm going to do very quickly is run across the panel here and ask in 1 or 2 sentences maximum if there's anything that we should have talked about that we didn't talk about. Anything you can think of that I forgot to ask you, or more importantly, all of these people forgot to ask you.
I would maybe like to highlight one research, a PhD research that is conducted by a military pharmacist. He's just looking at how to integrate local pharmacies into the national healthcare security resilience stockpiling program. And I think that is really something that is very promising.
And this is a real issue of medicine shortages, even now, actually, with all sorts of drugs. But this is something that, again, I'm sure we'll be talking about more. Ivo.
I think that we were talking about many different topics. That at the end of the day, the quality of these decisions around these topics comes to the issue of that the observatory is very strong about and has a lot of capacities in addressing these topics, is the governance, right? And the governance and the governability of the systems that depends on the economics, politics, and many other things, which is a Pandora box, of course. And I like the book that the observatory team produced a few years ago. It's called, it's Governance Stupid.
Yeah.
So it gives you a lot of kind of aha moments when you read it. It doesn't answer the question how to make it better, but it definitely something that we are shy to admit when it comes to the organizations or the countries, that our governance need to be improved. And the governance means many things. 18 frameworks were developed by the different think groups when it comes to the health system governance, but none of them answer the question, so what is actually the good governance when it comes to the practical issues and practical dilemmas. So I think that when we will be discussing many other topics tomorrow and after tomorrow, we will inevitably be thinking how we're going to organize it, because this is the governance dilemma.
Now, I'll declare a conflict of interest because one of the chapters in that book is written by A. McKee, but not me, my youngest daughter. And it talks about the principles of governance topic: transparency, accountability, participation, integrity, and capacity. And it's a very good way she'll be delighted if you cite it, actually, so she gets higher in Google Scholar. But leaving that aside, it is actually quite a very good way of looking at this. And I was talking earlier about the UK's COVID inquiry. You know, it's easy because it's in English, so therefore it's more accessible. But it's it's hard work because the evidence sessions actually are quite lengthy and detailed, but they are incredibly revealing. And I would just encourage other governments to, and a number of them have undertaken their own inquiries, Sweden, for example, and elsewhere, but really to look at what can be done, because if we're really going to learn lessons, obviously there are technical lessons, there are medical, clinical lessons, but above all, what we are seeing is the governance and the political lessons that we need to learn. And I think it's incredibly revealing. Wolfgang.
I'll be short. All of these lessons learned discussions always about reflecting what is basically written after the past pandemics. I mean, it's a kind of a repetition very often. What we should not forget is that we were, to a certain extent, lucky that we had to deal with COVID-19 as a virus with a relatively low fatality rate. If we had something with a fatality rate of 2 or 3%, the world would look different today. So I think, therefore, it is not time to forget about preparedness. That does not mean that we need to refurbish everything, but we should look at the plans. We should make sure that the capacities are there, and then we should look at processes and procedures in place. At the end of the day, what was not mentioned today here in this discussion is the word implementation. So decision making is one thing, but implementation comes only with the right staff, the right capacities, and the right funding, and based on whatever decision is taken by those that have to take these decisions.
And the decisions should be informed by talking to the people who have to implement, because one of the things I keep saying is, and I think this is where Finland did it well, and other countries, many of the problems that we saw in countries that performed badly was that decisions were made in central government without talking to the people on the ground. There was not that exchange of information. Isabel.
Communication. We haven't talked enough about that today. I mean, at the different levels, communication with the public, communication to the politicians. We need to learn to say, I don't know. I have no idea what is going on. I am doing my best. I'm working on that, but I don't know. And also, even if I think that the citizen responded very well for what was doing, 3 years after, we still haven't transmitted how to wear a mask. And and all of you see still in the planes people that still wear a mask that is here. So the basic things we have not been able to transmit to the population, but I think that we need to be realist and also saying things are changing, things can change. Yes, could be right that you vaccinate pregnant women when you have been told nausea that you never vaccinate pregnant women when you were studying in the faculty, or different things. Science is something that is moving, and science is something that needs to be learned to be transmitted.
Yes, it is interesting to watch how science is something that happens to other people often, and you do wonder what some of our political leaders were actually doing when they were at school, because the laws of physics haven't changed that much. Lisa Marie.
Thanks for mentioning
Lisa Marie, from the country with some of the highest educational scores in the world in the PISA test, so you don't have the same problem that many of the rest of us do.
And even though we are always criticizing ourselves of not being good enough. Okay, well, thanks for mentioning science, because I think that science is one of those things that could combine or bring together EU member states and non-EU states, and the experts and universities could build networks. But I thought about a little bit different point of view, having been listening the past 2 days of discussions in the summer school and this panel. Well, I think that we have not noticed enough as health experts the societal and political trauma of the COVID pandemic. And I think that other industries, political parties, even other international organizations are asking, why wasn't the health sector able to sort it out quicker so that they, or we, as societies, could have continued our lives as if the pandemic never happened? And this is confused with the direct impacts of the mitigation efforts, the trauma of the pandemic per se, and what we did about it. And since we were not good enough, because the other thing, people think we were not good enough, this did not happen. And that's why health has actually become part of the global power play. Because we keep telling that this will happen again, and we will again need the support of other industries, other policies, other ministries. So we won't go away from the agenda. And that is something that we have to cope with and develop a way to talk to other sectors, other ministers, other research communities in a constructive way.
Thank you very much indeed. So thank you to our panel for covering a wide range of questions, and particularly so because they got no advance warning of them whatsoever from me, partly because I didn't know what I was going to ask them when I stood up. But at least we've had, I think, quite an interesting conversation. And thank you to Una and Rachel at the back for fielding the questions from beyond the room. And with that, just thank you all very much. Please give our panel a round of applause. And over to Joseph. Thank you all very much. Thank you. I hope you enjoyed.
Hello? Yes. Well, this is when the speaker says, you know that the stereotype is the only thing left between the Aperol Spritz and the Prosecco and the reception, and the last thing you want is to read 7 pages of beautiful, amazing insights of what happened today. The bad news for you is that we've been told that reception is not at 6:45, but at 7. So I guess Antonio and I need to fill 20 minutes to entertain you, right? It's okay, it's okay. We have the group photo, and we have other things to do. I was wondering how one could sort of come up with some interesting ideas. First to say, of course, thank you for those live here and for those online. We started with a school in a nutshell, with a good advertisement for those online to join us next year or the following year. I think it's interesting, Reinhard, that in few minutes, you highlight what the summer school is about. And I believe very much on highlights. I believe very much on big structures or big architectures to get a sense of what is really important in this global security. We talked about the global health threats. We talked about health getting in the higher league. We're saying that today as well. Health about security, economy, foreign policy, investment. Perhaps wishful thinking. We talked about One Health. How many years, Marty, we've been talking about One Health, and now we believe that perhaps, thanks to COVID, we'll be having One Health, and it's the theme of the summer school tomorrow. We talked about the resilience of the health systems, and we talked about the global health architecture. That's the kinds of things we'll be talking about in the summer school, rather. And interesting, very interesting, sorry to repeat that so much, when the participants at the end said, what's in your mind? What hasn't been said? It wasn't about sophisticated plans, organizational structures, architectures, new regulations, new incentives. It was, Igor, is the governance stupid? It was Wolfgang. It's all about implementation. It's all about decision making. Isabel, it's about communication and knowledge to practice. It's about the politics. It's about the personal. It's about the training. So it's quite interesting that after all, a session that was in global architecture, even Christian that comes from the army, I always have this idea that the army is the Navy. Apologies. Well, for me it's the same. They're different. I know you guys think they're very different. For me it's just the same.
but it's not. I know. I've seen plenty of films, so I understand that. Seriously, I was very, very impressed, Christian, when you said it's personal interrelationships. And then came from a structure that is known to be hierarchical, very well organized, where everyone has their role, their rules, their lines, their orders, their command and control structures. And yet you are saying actually knowing each other, interpersonal is very important. I got a friend, a French colleague, a friend that's general in NATO, and so on, he was telling me about the same point, coordinating between NATO, that the personal relationships was the most important thing. So I felt that there was a lot of that. And that came very clearly already in the first session, if you remember, the session about the local level, what the regional is doing. So we're hearing about plans, but then we had the messages of politics. We heard about One Health, and then we saw the complexities to work with environment and with agriculture. We heard about antibiotics use, and we heard about how to work with those professionals, how to bring them on board, how involve them. So again, we have this element, this personal element, this health workforce involvement that came throughout very much in this session today. And the same element of personal interrelationships, when we heard of the simulations from our Veneto colleagues, the impression they got, it was, yes, testing the plans, testing the mechanisms, but they said as well, knowing each other, exchanging, learning how to work together. A lot of importance on this engagement, a lot of importance on this training element. Then what we got, and I'm finishing, I promise, we'll be out of here very quickly. We got this session, the global health architecture. I got the sense, Martin, that you are doing a testing. Martin is gone. He was trying to do a shock test to see whether in practice this can work. And I started, what's your telephone number? Remember Henry Kissinger, when, you know, many of you probably, you don't remember Henry Kissinger anymore, Secretary of State for Reagan, said, when I call Europe, I don't have a telephone number to call Europe, right? In some ways, that was the point that Martin was saying. What's a telephone number? And do everyone talk to each other? So we've been testing the system. I wanted to ask you whether they passed or not. And you in the summer school, not those online, I'm sorry, will be able to keep testing them because we're very lucky to have them accompanying us and talking about what actually they're doing. So we'll continue testing them whether they passed the test. And you test them on collaboration. We test them on the twilight zones, like the UK, I guess. Serbia was very good, the Serbian participants saying, what about us? Do you have collaboration programs? You keep saying that viruses cross borders, but do you have enough programs there? I think they kind of passed some of the tests there about what they are doing, although there was a bit of a sense, perhaps of not enough, perhaps a need for even more collaboration. I got the sense, I like to think as well of the political will. There was this thing about the vaccinations calendars. There was this question from Martin, what happens when a member state basically doesn't report back to you or doesn't pick up the phone? Do you, Isabel, have the leverage over them as you don't have for vaccinations? Yes or no? So there was a lot about this trust, this personal as well. Although I like very much what Lisa Maria said, I always like what she says. I learned a lot over the years from Lisa Maria, says, but it's not enough. Because if the trust is not there, you need a strong legal structure. And I think that wrapped up very nicely. There was a question I was trying to put on the table, and I couldn't, but I'll put it now to leave it in the back of your minds. One area that excites me a lot, Isabel, Wolfgang, Ihor, is the joint purchasing. I know we cannot talk about that. Wolfgang was saying we are last resort, joint procurement, financial contracts, framework contracts work very well to vaccines. Why can we not expand joint procurement for other pharmaceutics? And indeed, Ihor, there was this idea that WHO could put this framework contract and you done it from essential medicines. Why can we not expand and in Europe, at least in the European Union, purchase for 350 million? When we have already HTA, health technology assessment facilities at European level, when we have EMA and so on. I would have liked to discuss the next days how we can push forward with all this global health architecture and all the options and possibilities. And anyway, we'll be learning in the summer school about what went wrong with the national health regulations. A lot went right, Igor, but why we need a new pandemic treaty. Will the new pandemic treaty give us to that dreamland that many of us want to be, where there is a really international strong governance, and we can indeed, Igor, say, is the governance stupid? I have plenty of other things to say, but it's not fair because we are close. 10 minutes, a few more minutes for my colleague Antonio Maritati, for whom I thank very much always to welcome us here, to have the last points, and then we go to the photo. We all follow Annalisa over there. Please don't escape. Photo today, photo tomorrow, or photo Thursday, I can't remember. 2 photos, plenty of photos, and then the Aperol Spritz and the Prosecco. Antonio.
Grazie, grazie Joseph. Qualche piccolo spunto anche da parte mia.
Thank you very much, Joseph. I would like to make some comments so that we can conclude the meeting and join for an aperitif. This has been a really interesting afternoon, and we knew that because this Tuesday meeting of the summer school provides very important presentations of a high level. Some people on Sunday told me, I'm going to rest this week. This is not the case. We have very busy meetings, very busy days, and the participants do a lot of activities. Indeed, nobody can manage doing things alone. This is one of the key messages which emerged during the 2 round tables of this afternoon. All governing levels have to work together, and I mean at European, national, and regional level. The European Commission, Europe needs the member states, and the member states need to dialogue with their own local regions, with the local health authorities and the hospitals as well. We have learned how to implement all these ideas, in particular when the National Recovery Plan was adopted in Brussels. That refers to the healthcare assistance which has to be given in the islands of this lagoon. Nobody can do things alone. Nobody can be successful alone. When there is a change, for example, when it was necessary to distribute vaccines, we had to be supported by the army in Italy, because hospitals and vaccine centers could not manage alone. There was a major change in speed when the Italian army was involved in the vaccination campaign. Again, nobody can do things alone. The pandemic taught us that everybody has to be ready and prepared, and indeed well organized in the event of another emergency. This is a particular time in all European Union member states. The measures envisioned by the recovery plan are being adopted. In Italy, we had to make up for some inefficiencies at the level of local healthcare, digital care, and training. That regarded the entry of new healthcare professionals and other workers. It's important to continue to innovate, to experiment new routes. As we said many times, in the afternoon, it's important to have a clear and direct communication. We have to communicate the decisions which are made and how they are to be implemented. Communication in healthcare could be one of the subjects to be proposed for one of the next summer schools. I'd like to thank the observatory again, the staff, the directors, the co-directors, all those people who contributed, to the interpreters, whom we thank, and thank you for listening. I think that we can now follow Annalise.